Hey everyone, welcome into our lecture on management of care. All right, as you know, this is one of the areas of the NCLEX test plan. So let's go over some of the key topics they are going to ask you about regarding management of care. All of your prioritization and delegation falls under this category, all right? Establishing priorities, making those assignments, delegating tasks, and supervising those tasks that have been delegated. So I won't be going through all of that today since you have a separate lecture dedicated to prioritization and delegation. And that lecture falls under this management of care topic. So make sure to give that a listen and do a lot of those practice questions. Now, some other things that will be asked about: legal and ethical concepts, continuity of care, IT, making sure you can appropriately use that information technology, referrals, performance or quality improvement, organ donation, collaborating with your interdisciplinary team, case management, and concepts of management. So we'll look at each of those different areas, do some practice, and just go through that high-level subject of what the NCLEX could ask you. We'll start out on the legal and ethical concepts front. And if you need a more in-depth review on this terminology, make sure to check out that legal and ethical concepts video. First, let's go through your terms. Justice is fairness, so making sure care is distributed evenly, fairly, and being equitable. Beneficence is when we as the nurse do something good and take initiative to do something right for our client. Versus with non-maleficence, we avoid doing harm. That is intentional or unintentional harm. Accountability means to accept responsibility for your actions, all right? Your nursing care, your actions, your responsibility, no matter the consequences. If you make a medication error, you are responsible. Fidelity means faithfulness. I always remember the F for fidelity with the F for faithfulness, keeping your promises and being true to all professional responsibilities. Now, one of our favorites, autonomy, means the nurse is accepting that client as a unique person. And that means they have the right to their own opinions, perspectives, values, and beliefs, the right to self-determination. They get to decide if they want or do not want a certain treatment. And we don't get to judge or coerce them, even if it's a different decision than we would make for ourselves. That's the right to self-determination. And we as nurses respect autonomy. Now, veracity means telling the truth. This is the whole truth and nothing but the truth. We don't get to tell lies of omission or withhold parts of the truth. People are doing it for their good. They're going to receive bad news, and we don't want to tell them the whole real truth because we're worried that they'll get upset. That is a lie of omission and would not be following the ethical principle veracity. So take a peek at this NCLEX question here. Which ethical principle is accurately paired with the way it is applied to nursing practice? I'll give you about a minute and we'll review. All right, correct answer choice here, C, veracity, telling the truth. All right, fully answering their questions and not withholding any information does appropriately apply that ethical concept of veracity. A, beneficence, that is doing good, not doing no harm for the client. Remember, that's non-maleficence. I always remembered non for not, non-maleficence, no harm. All right, and then B, justice. Justice means fairness, so distributing care equally and equitably, all right? And D, fidelity, that's faithfulness, making sure we keep our promises. All right, let's explore some of these legal concepts. The very first, an advance directive or a living will. Now, it's important to note that a living will is a type of advanced directive. And an advance directive is a set of instructions someone prepares in advance of ill health. It lets them know what their wishes are in the event that they're not able to communicate those wishes themselves. Living wills are that specific type of advance directive for when a person is terminally ill. Now, these are both legal documents prepared to help the client communicate their own wishes. And that could be a whole spectrum of things. A do not resuscitate order. It could specify that they do want to be a full code, or even specific interventions that they do or do not want. Maybe they do not want antibiotics, a feeding tube, parenteral nutrition. Maybe they would not like to be ventilated or placed on the ECMO life support machine. It can be as specific as the client wants, stating exactly what they do and do not wish for. Now, a few things that are good to know about these documents as they apply to our nursing practice is that if EMTs are summoned to a scene, someone calls 911, maybe someone has passed out and is unresponsive, those emergency medical technicians are legally obligated to provide life-saving care. It's outside of the scope of their practice to evaluate and determine if that advanced directive is applicable. All right. So that client will need to be taken to the hospital where the healthcare provider can then, if applicable, implement the advanced directive. Now, this can get a little bit tricky when we have clients maybe on vacation or moving, traveling state to state, because these are state laws. So it's essential that if your client is going to be moving or even maybe just going on a long trip, that they look at if the state they're traveling to will honor their advanced directive. Sometimes they don't. They might need their lawyer to draw up an advanced directive applicable to that state. Now, advanced directives never expire. All right. They are good until that client has passed away or created a new advanced directive. If I had stated that, maybe I didn't want to be intubated and mechanically ventilated, and later I changed my mind, I can make a new advanced directive, and that new one voids the old one. The most recent or current advanced directive will be the legally binding document that my healthcare providers will follow. Now, what happens when we get in that sticky situation where a client is incapable of making their own decisions, in a coma perhaps, and we don't have an advanced directive? We don't know what their wishes are. Well, that decision-making ability will default to a certain member of the client's family, again, based on the state they live. In some states, it will be their parents, in some, their spouse. I know, for example, where I practice, the spouse is the first line that we go to, then the parents, and then the next of kin. And if they don't have any of those family members, or we cannot find any, and decisions have to be made despite our best efforts of locating someone who can tell us what these clients' wishes are, we will have two healthcare providers who will independently evaluate the case, make decisions, and make that decision together. That way, the weight of it isn't all on the shoulders of one healthcare provider. And, hopefully this doesn't happen too often. Hopefully we can find that family member that's able to communicate wishes for what that client would have wanted. Now, we call that family member often the medical power of attorney. This is another legal document. All right. So far you've got advanced directive, living will, and medical power of attorney. And what a medical power of attorney document does is specifically designate that person. Okay, this is who is making my medical decisions. All right, regardless of the state's rules about first it goes to the spouse, then the parents, etc. If you have a medical power of attorney, that's who's going to make the decisions. If you don't have a medical power of attorney, that's when we would follow those guidelines that will be specific to the state where you live and practice. Now, good news, the NCLEX is not going to give you an impossible question. It might be hard, but not impossible. So they won't be asking you who that decision goes to, as it does vary state to state. Okay, those are legal documents I want you to be aware of. Let's look at 3 different federal laws that you should have a little bit of knowledge of as they apply to your nursing practice. The first is HIPAA, the Health Insurance Portability and Accountability Act. We're going to talk about that in depth in a couple of slides. The second two, the ADA and EMTALA. ADA is the American with Disabilities Act, and as you can summon from the title, it prohibits discrimination against those with disabilities. So this is really important to hospitals because we have to make sure they are open and accessible to people of all abilities. We need wheelchair ramps, elevators, wider doorways. We need to make sure that no matter the disability, anyone is able to access healthcare and they can get to our facility. Now, EMTALA will come into play, particularly if you ever work in an emergency department. This is the Emergency Medical Treatment and Active Labor Act. And it says if you come to a hospital, we must provide treatment. We don't get to turn anyone away, regardless of their insurance status, their job, their ability to pay. They have a medical need and they show up to that emergency department, we are treating them. So this can get a little bit sticky in a couple of different situations. We know that sometimes clients come to the emergency department when they aren't truly having what we as nurses would deem an emergency. Maybe more of a primary care or possibly urgent care situation. They utilize the emergency department. Well, if you're sitting up at the triage desk and someone comes in and they're like, yeah, I got a little cut or a splinter on my finger. And you're like, my good gracious, you really came to the emergency department? You should really just go down the street to the doctor's office. It's going to be way less expensive. Don't even bother. That's a violation of EMTALA. Someone showed up to the emergency department, we are obligated to treat them. So you don't get to tell anybody to go down the street, go somewhere else, even if you feel it's appropriate. That would be considered turning them away. It's also very applicable when we transfer clients to another facility. There are certainly times we appropriately transfer somebody from the emergency department to perhaps a long-term care facility, a long-term psychiatric facility, are two that I have seen very frequently. And we need to make sure that our paperwork is crystal clear and good to go so that we show that this is an appropriate transfer and that we're not, in fact, turning them away. All right, we have to be very careful about this. Okay, a few legal terms that could come up on your NCLEX. Tort. This is a wrongful act or infringement of a right. Negligence. This is when we fail to take proper care. Malpractice, improper, illegal, or negligent professional activity. So negligence, a type of malpractice where we're failing to act. We're not taking an act that's wrong. We are failing to take a proper act. So for example, perhaps our client is on bed rest. They're not able to turn themselves. The standard of care, we should be turning them every 2 hours. If we don't go into their room but once on our shift, we just leave them supine the whole shift. The next shift comes on and we've got a 3rd-degree pressure ulcer on the sacrum. Well, that was negligence. You failed to take a proper action. You failed to meet the standard of care in doing something. And that negligence is a type of malpractice. Professional activity, it was improper, illegal, or negligent. All right, assault and battery, I find, get mixed up. We say all the time, oh, they assaulted me. Well, an assault is an act that threatens physical harm. All right? If somebody actually puts hands on another person, that unconsented physical contact, that is battery. All right? Assault, threaten of that physical act, battery, unconsented physical contact. And lastly, and very applicable to nursing practice, is false imprisonment. Okay, false imprisonment is the state of being imprisoned without legal authority. Okay, 2 ways that I see this play out in nursing. One is with restraints. All right, if we put 4-point restraints on somebody or any type of restraint, and we do not have a good reason, they are not a danger to themselves or others, that person is being falsely imprisoned. If we hold somebody in a facility, an emergency department, a psychiatric facility, and we do not have legal authority, that is false imprisonment, which again, this can be tricky. If the client doesn't want to be in the emergency department and they are of sound mind, sound body, there is no legal authority saying otherwise, they get to leave. They can leave against medical advice, AMA, right? That's not our business. They get to do what they want to do. If they are a danger to themselves or others, then we need to follow proper legal procedure and obtain what we call an IVC, involuntary commitment. That paperwork comes from a judge who says, yes, this person needs to be in a facility for their own or others' safety. And it takes away that client's legal authority to leave. So, gist of it, if they're not a danger to themselves or others, they get to leave if they want to. And if they are, follow those proper channels and make sure that IVC paperwork is in good shape so that you have legal authority to keep that person. Otherwise, you're committing false imprisonment. Okay, I said we were going to circle back to HIPAA here, one of those 3 federal laws that are important for you to know on the NCLEX. This, of course, stands for the Health Insurance, Affordability, and Accountability Act. It essentially is what we follow to make sure we are protecting our clients' health information. All right. There are very specific rules about sharing info regarding clients' health. And the rule is if someone doesn't need it to do their job, then we don't share it. All right. Our buddy nurse Sally down the hall, she's like, oh, what's going on with your patient? She wants to gossip with you. No, we're not sharing info unless Sally's coming to relieve us for lunch and she needs to know that client's med schedule to be able to care for them. In that case, totally appropriate. So whenever you're going to share something, ask yourself, does this person need it to do their job? If the answer is yes, you are safe. That's appropriate. If they don't, then we don't share it. We can share info with the family of the client with the client's permission, right? The client gives us their permission, and if they would like us to share that information, that's perfectly fine. Now, what do you do if Billy Bob Joe calls and he's like, hey, my cousin is in the hospital, this is her name, whatever. Can you give me an update about her? All right. We don't share medical information. We can share what we call directory information. Now, I don't know about you guys. This is something I felt like I didn't really understand in nursing school very well, and something I probably got wrong on my own NCLEX. What directory information is the client's name and the location of the facility, like a phone book, a directory, okay? Directory information is not included under HIPAA. It's not health information, right? How are they doing? What's their medical condition? What are their lab values? That's all health information protected under HIPAA. But their name and the facility location, that's just directory info. And we can share that. The only exception is if the client has opted out of being in the directory. For example, maybe this is a victim of domestic violence and they would like to be listed under an alias and they don't want anyone who calls to know where they are. That certainly happens. And that would be a very important reason to ensure that they are not included in the directory. So you have to know if your client has opted out, but if they haven't and someone calls, you can share their name and location. That's it. Nothing else. How and what else can we do to protect our clients' info? All right, well, we know we're charting electronically on most facilities now. When you leave your computer screen, there is a wealth of information included there about your client. So make sure to turn that screen off or go to, exit out of the charting system so that there's not information up on that screen when you walk away. You don't want to walk away and leave information up there. You also want to be really careful not to be chatting about patients in a public place. And I know that sounds quite obvious, but it can actually be quite hard. Perhaps you're going down to the cafeteria with the nurse who's next door to you. You're in the elevator and, she might need info to even do her job, or you're sharing care for a patient and you're talking about it, which would be appropriate in a private space, but you have no idea who else is in that elevator. It could be somebody who knew them from elementary school. They figure out who you're talking about, and all of a sudden they're posting all about it on Facebook. You want to be really careful about that type of stuff, all right? Client information is sensitive. It is their info, and we don't want other people to have it unless they choose so. Now, if you have paper docs, you need to shred those when you're done. Always turn them face down at your desk. Put them in a secure place. They never, ever leave the healthcare facility. All right. A big thing with this is the report sheets that you will likely use as a nurse. Can't take those home. They have info on them. You don't stuff them in your backpack and hop on the bus. Nope, you got to shred those. Paper docs that have any info need to be shredded. It should go without saying that we do not post info about clients on social media. We certainly don't post pictures. Really, if you're taking any picture in the hospital, even like, oh my gosh, it's my first day as a nurse, look at me in my scrubs. I totally get it, but you need to be super, super careful because there is all sorts of protected health info in that hospital. Doors have room numbers with the client's last name on them. There's computer screens with info pulled up. There are charts and records all around. There's monitors that probably have the client's name attached to them. Lots of things in the background of your photo can be protected health info. So I really avoid photos in the hospital, okay? Do not store protected health information on your own computer or send it to your personal email. We want to make sure it is encrypted and in the facilities database, not going outside to Gmail and Google where it can get all over the internet. And a biggie is that you never ever open a chart of a client you're not taking care of. All right. If you're like, oh my gosh, my neighbor, she's having a baby and I'm wondering like, oh, how many centimeters is she? Is she close to having her baby? Yeah, you don't get to pull up her chart and check. That is not your info. So let's talk about that documentation, that charting. This is another part of health management, care management. If it wasn't documented, it wasn't done. I'm quite sure that you have heard this by now, but when we're talking about case management and such, it's worth bringing up because your charting, that client's chart, is part of a legal document. Their medical record can be utilized as a legal document in a court of law. Actually, for up to 10 years is what the client has to bring up a lawsuit regarding their care. I don't know about you, but I definitely could not remember what I did 10 years ago if a lawsuit happened to come up, and I would not be able to defend my own actions without knowing the context. So I have to document that really, really thoroughly. Other healthcare providers see it and utilize it for their care, and the client can see it. So you want to make sure that it is very thoroughly documented. Joint Commission, Medicare, Medicaid, different agencies for quality assurance, they can all access this record as well. So dance like no one's watching and chart like it one day may be read aloud in a deposition. All right. Here's some do's and don'ts for you to follow. You want to chart in real time. Early charting, not good. You have no idea what could happen to that client in the next 10, 15 minutes before you actually go do that intervention. What if I chart that I'm going to administer this enalapril, and then 15 minutes later, I go in there, I check a blood pressure, and it is 80/30. Well, I'm certainly not administering my enalapril, but I've already charted that I have given it. And now I've just charted a low blood pressure. It's going to look like they had a reaction to their enalapril. And that's not even what happened. So pre-charting, no. And, delayed charting, we're all busy. I know it's impossible to chart right at the second that every single action happens. But the longer we wait, the worse our memory gets. So we want to chart as close to the time as we can. We only chart under our name, not for someone else, not under anybody else. We don't let anybody else chart for us. That's falsifying the medical record. But I document, it says I did it. So if somebody's like, hey, I took this blood pressure in room 2, can you throw that in there? Well, that says that I took that blood pressure and I didn't. So that is false information. All right. You never trust anybody. All right. You don't trust any other person but yourself. I'm not tying my name to their blood pressure because I have no idea if they did it correctly or not. And if there is some sort of bad outcome related to that, I don't want any part of it. All right. You want to chart things as accurately as possible with no subjective opinions. Okay. So sometimes our clients are not always like the nicest humans in the world. They're sick. They don't feel good. Sometimes, things happen. Okay. So if your client says, get out of my room, you ugly cow, here's how you chart that. You say, patient stated, and you quote Get out of my room, you ugly cow. No matter what. Okay, you put it in quotes. That was their words. It is exactly what happened. There is no opinion about that. It is just accurately what went down. What you don't do is say, patient was rude to the nurse. I don't like this patient. You don't give your opinions, nothing subjective at all. Okay. This brings us to talking about informed consent. All right. Of course, informed consent is when we validate that a client knows the risks of a procedure, whether it's, maybe a line being placed, maybe they're going for an open heart surgery. It can be a range of different things. We, as the nurse, the registered nurse, do witness informed consent. We sign, we put our title, RN, and it signifies that we have validated that client's name and their identity. It doesn't say we taught them about the procedure. It doesn't confirm that they understand. It doesn't mean that they are fully informed and they know everything there is to know and they don't have any other questions. It doesn't mean that we can testify that, yes, they were provided with the appropriate knowledge. All right, that is all outside of our scope. That is what the healthcare provider does. We are there. We witness the education. We say, this is that client. They got that education, and we verify. That is all that is within our scope. Okay, take a check at this NCLEX question. Give you about a minute here, and we'll review. Of course, excellent. C, self-determination. That's really what informed consent comes down to. The client gets to know the good, the bad, and the ugly, and they get to make the call. So informed consent does go a long way to that ethical principle of autonomy and self-determination. All right, let's go a little bit deeper into the information technology, the IT. We use a whole lot of IT in the hospital, don't we? We've talked about the electronic medical record, that EMR. Part of that EMR is the medication administration record, that MAR. So we do a lot of barcode scanning. We scan the client, we scan the med. It goes into that medication administration record. And that's really helpful because that's a very safe way to correctly identify your client and your medication. Sometimes we see automated orders come in from healthcare providers. The location where I've worked have called those order sets. So for example, if a client comes in and we suspect sepsis, there's an order set they can click and it will order blood cultures, fluids, antibiotics, and all the things that we need to do within 60 minutes. We also, at most facilities, have something called the intranet. So it's an internal internet system that's going to have policies, procedure, probably your scheduling portal where you can clock in and out for your lunch break, and even utilize websites and tools to check IV compatibilities. Look up a medication you haven't heard of. Obtain CEUs or continuing education. There is a lot that we do online. All right. Now, the biggest things that I see the NCLEX ask about when it comes to IT was the HIPAA stuff, protecting your client's info, how you access data, and receiving and transcribing orders. This does come up pretty frequently. Ultimately, the nurse is responsible for making sure an order is appropriate. You must review that order, make sure it's complete, it has all the details that you need, you understand it. And remember, if you don't, or if you're like, wow, that dose really seems inaccurate. Perhaps the healthcare provider ordered 40 milligrams of ondansetron, and the standard starting dose is 4 milligrams. You're going to really wonder, okay, is there a reason why we would give 10 times the normal amount? Or, perhaps everyone's human, perhaps they hit an extra 0 on the keyboard. It's your job to clarify. If it's illegible, you clarify. All right. If it just seems weird, if it seems inappropriate for your client, maybe they're hypotensive and they order nicardipine, right? You're going to say, really? Do we want to lower their blood pressure any further? You ask. I can't tell you how many times a provider has put an order in and it was for the wrong client. That we are all human and very, very busy. So those things happen. Your job to clarify. Now, let's talk about verbals. Telephone and verbal orders. These are discouraged. They are not best practice. Higher rate of errors occur when we accept verbal and telephone orders. You are allowed to refuse to take a verbal order. If it is an unsafe situation and you do not think that taking a verbal order is the best action for your client, it is absolutely okay for you to say, I'm sorry, Dr. Smith, I can't take a verbal. Please enter that in the medical record and I will follow that order to a T, right? Because when the doctor is entering it, the healthcare provider is entering it, they see it, they have to choose the dose, the time, the actions, etc., and it's much more likely to be correct. Now, if you do take a verbal or telephone order, you need to document that you did so and why it was necessary. All right. Maybe it was an emergency situation. I promise I have taken many verbal orders when it's necessary. Maybe the doctor is off site. There's an emergency. We need to do what we need to do. That's appropriate. Take the verbal. What the NCLEX wants to make sure you know to do is do a read back. Read that order back to the healthcare provider so that they ensure it is correct. All right. So if they say, all right, 4 milligrams of epinephrine, that's not a normal epi dose, but you get the gist. You read back 4 milligrams of epinephrine and you read the whole order. They confirm, you document why you took the verbal. Okay, last thing with IT, accessing that data. All right, this for sure circles back to the HIPAA info that you only access info you need to do your job. You don't share it with people you don't. You log off from that workstation when you're leaving and never leave sensitive info up. All right, if you can remember those points, you'll probably be okay when it comes to those NCLEX questions. Let's shift gears now and talk about performance and quality improvement. There are a few ways that this can look when it comes to care management on the NCLEX. The first is in a management role, performance appraisals or evaluations. All right, so these help nursing managers make decisions about staffing, hiring, scheduling, promotions, deciding who's going to be a preceptor, a charge nurse. It sets the different expectations, make sure there's fair treatment and working conditions. It's also really beneficial for nurse retention, which is a big push right now. We're losing lots of nurses. We want to retain our nurses. So in a nurse management role, checking in, developing a relationship with all of your staff nurses, encouraging, compliance and good morale, those are going to be really important. And lastly, if, of course, there are any ethical or legal concerns, performance concerns that we've attempted to address and have been unable to, termination or discussions about termination should occur in these performance evaluations as well. All right, so which of the following here would be an element that a nurse manager should include when completing an evaluation? Take a look here. All right. A, B, and C are all appropriate items to address in a performance evaluation or appraisal, okay? Barcode scan rates, that's compliance, making sure we're following policies and procedures. The number of times they've been absent or tardy. Again, compliance, following the rules, following the regulations. If this is a consistent problem, they want to, evaluate why and see how we can address that. It's not appropriate to consistently be absent or tardy. C was helping the nurse achieve that national certification. All right. Now, different hospitals will have different requirements about this. It may not be required, but encouraged. It may be a consideration when it comes to precepting, a charge nurse, a promotion. So encouraging that and evaluating their ability or eligibility to pursue that certification, definitely appropriate. Now, D and E, these were not appropriate things to include. D was their performance compared to other staff nurses. Their performance, appropriate. Do we compare them to their peers? No. That is inappropriate. It should focus on their performance. And lastly, E, the number of medication errors the nurse has self-reported. That word self-reported was really important here, okay? Medication errors are absolutely something that should be addressed. But self-reporting should be encouraged, right? If we catch that we've given, the wrong dose because pharmacy sent something up in a syringe that was inaccurately labeled, we want to report that so that we can fix the system level issue that has caused the error. Self-reporting should never be weaponized or utilized in a performance evaluation to dock them or hold them back from a promotion, because self-reporting is how we all get better. All right. This brings us to our next management of care topic, which is organ donation. All right. Now, a lot of what I'm about to tell you is what you don't do with organ donation, which is a lot, because we have an organ procurement organization that's going to be in charge of this. All right. Of course, with organ donation, if you're caring for a client and brain death will likely be declared, the healthcare provider, the hospital, they're going to notify that organization. All right. Now, the name of that, it varies state to state. Even I've in the same state worked with two different ones. So you don't need to know the name of it. You just need to know it's an organ procurement organization. And that is who is going to lead all of the decisions, the discussions. They're going to approach the family. All of that happens with them. Okay, not the nurse, not the healthcare provider. That's not in our scope of practice. It is inappropriate for us to bring up the idea of organ donation. Now, what if a family asks about it? All right, they may know that this is coming. This could have been, a long road to get here, and they're aware of where things are heading. This could have been something they've talked about with their loved one, and they know that they would be interested in. So they may ask you about it. Your appropriate response is, good question. Let me get the appropriate healthcare provider, healthcare personnel, people, however you want to phrase it. Let me get the right person in here to talk to you about that. You don't give any info. You don't say, yeah, great idea. Or you don't say, no, why would you do that? You don't offer opinions. It is so outside of what you are qualified to do. You just get the right people in the room. Okay. Now, if you are caring for a client who has been declared brain dead and is going to donate their organs, our care really shifts focus to end organ function, which makes sense, right? Maybe they're donating their heart, their liver, their kidneys. We need to make sure that they are perfused with blood and getting good oxygen so that they're in the best shape possible for their donor. All right. So end organ function, making sure our lab values are good. You're going to be doing a lot of labs. I will never forget the first time I cared for an organ donor and I got the orders for all the labs I was going to do. And I was like, oh my gosh, can I even draw this much blood from is this even safe? It is a lot. You're doing a lot of tests. And, when you think about it, like in hindsight, it really does make sense because all these organs, these tissues are going into someone else's body. So we need a lot of information there. To be doing a lot of labs, maintaining their blood pressure, maintaining their hemodynamics, making sure those organs are well perfused. Well, we organize the surgery so that we can remove the organs and get them distributed appropriately. That takes a good bit of organization. That's what the organ procurement organization does. All right, this brings us to talking about referrals, moving towards our interdisciplinary team. What is a referral, right? This is when we refer care to another healthcare provider. Not necessarily like, hey, I don't want to take care of you anymore. You're going to go over to them. But in addition to the team. And it helps ensure completeness and appropriateness of that client's care. There are so many needs that clients have, and one healthcare personnel, they are not going to be able to address them all. All right. So therapists, that's a big person that we refer to. PT, OT, speech, RT. They're really, really going to be beneficial in helping with rehabilitation, helping the client reposition, walk, activities of daily living, swallowing. I mean, so many of those important daily activities are managed by therapists. Now, social work, case managers, you guys know the importance of them helping organize resources for our clients, making sure upon discharge, they have somewhere to go. They have the medical equipment they need. They have their prescription filled. What if they don't have the resources to fill their prescription? These people can help with that. Some clients may request a consult or referral to a chaplain or spiritual care, depending on their religious preferences. We may involve a registered dietitian, a nutritionist to help with their care plan, meal planning, food resources upon discharge. There's all those outpatient services. And that's not even mentioning all of our specialists. All right. We've got our primary healthcare team. We also have cardiologists, pulmonologists, endocrinologists, gastroenterologists. The list goes on, right? So for clients with complex medical needs affecting many systems of their body, there are a lot of providers involved. And that brings us to talking about how we collaborate with all those people. It's the interdisciplinary team. We have conferences, we have meetings, and the nurse is often at the center of this because you're the person at the bedside who knows the client the best. You're spending 12 hours, if you're working in an inpatient setting, right there with them. You are the eyes and ears of the interdisciplinary team because they can't be there. They have tons and tons of other clients. So you're going to really be a focal point of those team meetings to help get all of those different opinions together in one room and collaborate for the benefit of your client. Now, how do we report and communicate all of this information? All right, there's a few different times and settings where we have to communicate information, whether it's in a team meeting, handing off from one provider to the next at shift change, or perhaps from one provider to the next when you're transferring to a different area, specialty, being discharged, etc. And a very, very common mode of reporting information is that SBAR, okay? There are a lot of different, little ways that we might report, but this is what I see most commonly used. You tell the situation, the background, your assessment, and recommendation. Pretty short and sweet. Let's look at an example. The S and SBAR for situation. The client presents to the ED. They had upper respiratory signs and symptoms, dyspnea, tachypnea, and a productive cough. Okay, overview of the situation, kind of what's going on. Then you get into the background. All right, so this is a 57-year-old. They've got a history of CHF and COPD. All right, so that's what had been going on, brought us to this situation. All right, then what's your assessment of them? All right, so pertinent vitals, focused assessment findings, focused lab values. This is not where you read your head to toe assessment. All right, they don't care. They don't need all that information right now. They need what is pertinent. All right, so respiratory status is worsening. Retractions have gone from mild to moderate. They're nasal flaring and grunting. They're tachypnic, their respiratory rate's increasing. Here's what we've done. We've given albuterol and oxygen, hasn't improved. All right, down and dirty. Pertinent respiratory assessment. What's it trending? How's it looking? What have you done? And what has your evaluation of that action been? So here we see we took the action of nebulized albuterol and oxygen. Our evaluation is that it's not improving. And that leads you to your last little assessment recommendation. Your recommendation, hey, notify the healthcare provider and consider intubation. All right. So if you're going through this with a healthcare provider, let's say that you're, at this client's bedside, maybe they're in the emergency department, and I am not liking how this client is looking. Here's how I might throw this SBAR together for the healthcare provider. All right. Hey, Dr. Jane, we've got a client here. presented for upper respiratory signs and symptoms, dyspnea, tachypnea. They're a 57-year-old with a history of CHF and COPD. And I'm calling because their respiratory status is worsening. Their retractions are getting worse. Now they're nasal flaring and grunting. Their respirators continue to increase. She's severely tachypnic. We administered the prescribed albuterol and oxygen, and I'm not seeing any improvements. I would like for you to come to the bedside and consider intubation. Guarantee you that's going to get your provider to the bedside. But see, that took less than a minute, down and dirty. So that's why SBAR is so good. Make sure you know kind of what it stands for, but more importantly, be able to apply this to a client scenario. All right. That's the kind of critical thinking that you'll see in these management of care NCLEX questions. Okay, now the next part about management of care as far as your interdisciplinary team goes is knowing your chain of command. All right. So we talk about this a lot in delegation. You'll see there's a little bit of overlap between this component and that lecture. Make sure you're really confident about the scopes of practice of these different healthcare personnel. But of course, you have your unlicensed assistive personnel, your LPNs, and your RNs. From there, escalating actions up our chain of command goes to the charge nurse, the nurse manager, the nurse supervisor, and can even go all the way up to the director of nursing, depending on the situation. I have only one time had something escalated all the way up to that level. And it was when a client was admitted. It was a 9-year-old that was very, very ill. She was newly diagnosed with a brain tumor. The family had no idea, came on very suddenly, and it was a very poor prognosis. This was going to end poorly and quickly. And this was right in the middle of the COVID-19 pandemic. And we had really, really strict visitor regulations. We didn't want too many people in the hospital because we didn't want extra germs. So we would only let one parent come at the bedside. So the emergency department, when they got transferred over, they were being sent up to me in the PICU. The emergency department would only let the mom in. They sent the dad away, said, go home. So this mom was alone with her 9-year-old who I knew was going to pass away with no support and no family. And I did not feel that that was appropriate. So I escalated it up my nursing chain of command to my charge nurse. Well, it was out of her hands. So she called the nurse manager for the PICU. And the nurse manager for the PICU doesn't make the rules about the hospital visitor regulations. So she called the nursing supervisor for all of pediatrics, who said, yeah, this sounds like a really big problem. I agree that this is an issue and we need to advocate for your client, but this is even above my head. This is at the hospital level. So we need to call the director of nursing. And they did. And we were able to make sure that that family was together for what was a really, really sad day, but they weren't alone. So it's not common that you have to escalate through that entire chain of command, but it could certainly happen to you. And when you're applying this to NCLEX questions, you guys, you want to make sure that you are always advocating for your client. On the NCLEX, we put our client first. We make sure we do everything we can to advocate for them. And escalating concerns up the chain of command is one of those actions that they expect you will know to take. All right, so this brings me to talking about incident reporting. Last little thing here for kind of the interdisciplinary team aspect. And I want to talk first about kind of what incident reporting is. Incident reporting, it could be an incident, an accident, a medical error, or what we call a sentinel event. And this is ultimately done so that in the future, we can fix the cause. All right, what caused this accident? Why did this incident occur? We need to determine that cause because most of the time, it's not just one person's fault. Let's say, for example, there's a medication error, like we were looking about in our performance evaluation component. Nurse Joe accidentally administers, he gives Ativan instead of diazepam, 2 different benzodiazepines. he gives the wrong one, and the client's okay, but he has made a medication error. All right. Incident reporting includes that sort of thing: medication errors, accidents, all of those sorts of events. And when Nurse Joe does that, he helps us identify why that mistake happened. All right. Were those two different medications that they were lookalike, sounded like drugs? Were they right next to each other in the medication dispensing system? It'd be really easy to grab the wrong one by accident. It's not just Nurse Joe's fault. Why did pharmacy put them next to each other? Why were we using the brand names instead of the generic names, right? Is there something we could have been doing? Should we have labeled them with different colors so that it wasn't so easy to mix them up, right? System level issues. Let's identify those faulty processes and fix them. That's what incident reporting is about. As we mentioned, looping this back to performance evaluation, we do not weaponize that against an individual nurse, okay? So that's not used when a nurse does file an incident report. It's not used against them because that would discourage incident reporting, which is ultimately not beneficial for anyone. Okay, so take a look here, give you about a minute. Tell me what you think the answer is to this NCLEX question. All right. And the correct answer here, following your chain of command, is A. All right. Something's going on. Address that healthcare personnel, right? That's the beginning point. We don't need to escalate that further up the chain of the command until we have addressed that person. Okay. Next, let's talk a little bit about case management. Now, this is a really broad topic. I mean, we have an entire role or position at most facilities where we have a case manager. So what case management includes is helping organize all those miscellaneous pieces of resources to be available to your client. All right. So it's a lot of discharge planning, medical equipment, DMEs, durable medical equipment, helping plan care and coordinate discharge. So they have all the different components that they need in order to be successful. All right. What assistance do they need outpatient? Do they need a walker, a wheelchair, a Hoyer lift? Does someone need to go to their home and do a home safety check? Remember all of those home safety components we talked about in safety and infection control, right? Do they have throw rugs, fire hazards, etc.? Can they get up and down their stairs? I like to think of it as, what can we do to enable this client to have success outside of the hospital? All right, let's make sure they have the equipment, the resources, and the support they need for a successful discharge. And this really helps us reduce readmission rates. Because if we don't set our clients up for success, we send them home and we don't make sure they've got their prescriptions, their oxygen tank is half full, their wheelchair is broken, and they're not going to have anybody at home with them for 2 weeks. Well, that client is coming right back into the emergency department, and we have failed them. We did not manage their care well. All right, there are a few different nursing care delivery models for how we administer and deliver that care, specifically in the hospital. All right, so this is less about the case manager role, looking at the big picture, and more at the level of looking at the whole nursing unit in the inpatient nursing world and how we're managing those clients needing our care right then. The first, and what, in my opinion, most facilities now practice, is the total patient care model. So the RN is responsible for all aspects of the care during a shift. They can delegate, but they work directly with the patient, the family, and all the other healthcare team members. So the number of clients that the nurse is caring for should be lower since they're doing total patient care. Now, in the middle of that, we have primary nursing model. So the RN has a responsibility for a caseload of patients, and those are her patients. I see this more frequently in like a long-term care facility where these are your 7 clients, you're responsible for them. Every time you come on shift, these are your people. And lastly, team nursing, which I've heard some of my colleagues say that they have used in the past. I have personally never practiced team nursing out about in the real world. But team nursing is when team members provide patient care under the supervision of an RN team leader. So here's how that could look. RN team leader, all right, let's say we have a unit with 10 clients on it. And maybe then there are, 3 or 4 LPNs. The RN will say, okay, LPN number 1, you're going to do vital signs on everybody. LPN number 2, you're going to do all the meds. LPN number 3, I want you to be in charge of blah, blah, blah. You get the gist, okay? So there's a team lead and they divide up the patient care like that, all right? So once again, I haven't seen that in practicality, but that doesn't mean you won't see a question about it crop up on the NCLEX. So make sure you know these different care delivery models. Let's try a practice question here about them. Very good. Absolutely. D, that total patient care model is when they're responsible for all aspects of that client care during a shift. And again, that's what I see most commonly. Okay, next, let's discuss disaster planning and triage. Okay, there are different levels of disaster planning that you should be aware of: red, yellow, green, and black. You should know which of these colors signify what, and be able to read a client scenario and apply one of these colors or levels to that client. So the first clients we see are the red. If we tag somebody as red, that means if I don't go see this client right now, they will die. But I am able to save them. There is something I can do to immediately save them. A client who's in shock that needs vasopressors, a client with a cardiac tamponade who needs a pericardiocentesis, right? There's something I can do. I have to do it right now to save them. They're red. Below that, yellow. It's like, okay, they can wait for me to take care of this client in shock, but if I don't get to them in the next hour or so, they could have problems, like a big open fracture, right? They could be leading to further complications, so I need to get to them next. Lastly, green. You might hear this referred to as the walking wounded, or in the ED, we would say that these people are walkie-talkie. They can walk, they can talk. Maybe they're anxious, maybe they're in pain, maybe they have a closed fracture or some lacerations or abrasions, but they can wait for hours and hours and hours, if not days, and they will not die. This is all about who's going to die first. Lastly, black, they are either already dead or we are at the point where we can't save them. Either their injuries are so severe, it is absolutely impossible to save them no matter what, or given the resources and the setting that we are currently in, we don't have the ability to save them. Okay. That allows them to die respectfully with peace and dignity to the best of our ability. Okay. So they are prioritized last, which I know can seem cruel and just, it's not really a comfy topic to talk about. But when we're disaster planning, we're talking about who can we save first? Like, how can we save the most number of people given the resources that we have? So red, yellow, green, and then last, black. Okay, the next scary, sad, not so great thing that falls under this management of care are talking about our sentinel events. All right, this loops back a little bit to our incident reporting. Sentinel events are another thing that we report. These are events that have reached the patient and caused harm. So not just like Joe accidentally gave diazepam instead of lorazepam, client was fine. It's like we cut off the wrong arm in surgery. They died. We caused permanent harm to the client. All right. So for example, let's see, I had a coworker whose dad, I don't remember what he originally went into the hospital for, but it wasn't anything too crazy. He was going to be fine. The nurse inserted his Foley catheter and wasn't even wearing gloves. No sterile technique, not even clean. He later got a UTI, which progressed to causing kidney damage, and he ended up going on dialysis because it was so bad. He had end-stage renal failure, and that was totally unrelated to his original illness, whatever he went into the hospital for, okay? It caused permanent harm. That is a sentinel event. And we call them sentinel because it means we need immediate investigation and response. What the heck happened? Why did it happen? And how can we make sure it didn't happen again, or it never, ever happens again? Now, that was an act of negligence. That nurse did not follow standard care. We know we need to use sterile technique when we insert a Foley catheter. Not all sentinel events occur because of negligence or an error. It could be a genuine, mistake, or something that we don't expect goes completely awry. We still have to report it, incident reporting, and investigate so that we can figure out how we prevent this from happening in the future. So this is one type of event, patient safety event. All right. We talked about medication errors, sentinel events. We also have what we call an adverse event. So a safety event that resulted in harm. It's not at the level of a sentinel event, but for example, like somebody had a stroke after a procedure that could have, dislodged a clot. It wasn't due to negligence. We know it was a risk of coronary angiography. We know can cause an embolic stroke if a clot's there and we dislodge it, but it causes harm to the client. All right. So it's not negligent. It's an adverse event. A no harm event is when something happens, it reaches the patient, but it doesn't cause harm. So that was our example earlier when Nurse Joe accidentally gave diazepam instead of lorazepam. The event got to the client, but they weren't harmed, right? Those are very similar medications. They were okay. A close call is even one step below that. So that would be like if Nurse Joe drew up the lorazepam and then he was like, oh my gosh, shoot, I've got the wrong medication. And he realized it and he caught it and it didn't get to the client. He caught his mistake before he even made it, but it almost happened. It was a close call, near miss, good catch. My hospital always called them good catches. You could get an award if you had a good catch. You had a good catch award because they help us identify ways that we can get better, right? So maybe Joe was like, yeah, the lorazepam and diazepam, they are both labeled with these generic names. They're in the same color. They're right next to each other. Like maybe we should put them in different colors apart from each other so I don't grab the wrong one next time. That improves our processes and prevents errors in the future. So we hope to have lots of good catches. No harm. It occurs, it gets to the client, it doesn't cause harm. Adverse event, it causes harm. Sentinel event, death, severe, permanent harm. Last but not least, we also want to report hazardous conditions or unsafe conditions. A big topic with this lately is staffing ratios. If you come into work and you're in an ICU where your patient ratio should be either 1-1 or 1-2, and they tell you you're going to have 4 clients today, that is an unsafe condition and you need to report it. All right. Anything that increases the probability of one of these events happening should be reported so that we can figure out what's going on and correct that condition that could ultimately lead to an error. So those are your types of events. Incident reporting, very important. And remember, should not be weaponized against the nurse. Okay. NCLEX question about this. All right, good job. Yep. C and E. C and E are examples of sentinel events. Those events got to the patient and it caused serious harm, caused a fracture. In E, we did a colectomy instead of an appendectomy. That client is really not going to be happy when they wake up without their colon and all that needed to happen was their appendix needed to come out. That's a pretty big deal. Permanent, severe harm, it reached the client. All right. A, an untimely assessment, or B, an incomplete assessment. Okay. Those are things that could ultimately contribute to one of these events, but in them of itself, they aren't classified as an event. Harm has not reached the client, or anything hasn't even been caught before it reached the client. But incomplete and untimely assessments can be a precipitory or contributory factor that lead up to one of these events. All right. And then lastly, D, the wrong client was almost sent. Okay, well, then that is a near miss or a good catch. We almost really messed up, but we didn't. We caught it. We fixed it. Harm didn't reach the client. Do we report this? Yes. Yes. Incident reporting, very important here. We make sure that we report this incident and evaluate why it almost happened so that we prevent it from almost happening ever again. Okay, last concept to go through with you all. Let's look at different concepts of management and management styles. So if you are ever tapped to become a nurse manager, you must make sure to know the roles of all your team members. Delegating and prioritizing is going to be a huge part of these management questions. Care planning, looking at the overall big picture strategy and making sure to act as a liaison between the staff nurse, the family, the staff nurses, and the healthcare providers. That means that you're likely going to be managing some conflict. That occurs. That's a part of life. Now, there are a few styles in which people do this. An autocratic management style is when that manager makes all the decisions. In democratic management, we make group decisions and the manager supports. Participative is when the staff provides input, but ultimately the manager is going to decide. So maybe there's a sentinel event, they call a team meeting, everyone provides input as to why this happened and what they think should happen moving forward. The nurse manager takes that input, but they ultimately make the decision. And then lastly, laissez-faire is where there's very little structure. There's a manager, there is management, but that support and that structure is not really there. Okay, so of course, going into new graduate nursing, I know you're not immediately going to be managing, but the NCLEX may ask you questions about these different styles. So take a quick look here. If a medication error occurs and a thorough investigation was performed, the nurse manager does a memo talking about the changes that need to happen. Which of the management styles that we just talked about, democratic, participative, laissez-faire, are these talking about? Look at that scenario. What type of management style is happening here? Yes, absolutely. A, autocratic, definitely. They're not asking for input, right? They didn't, ask the staff nurses to come to a meeting so that they could chat about it and see what the best action would be. They didn't get any input. They just sent out a memo. They made the decision. That was autocratic. All right. Now, some initiatives that you might see asked about when it comes to management. Benchmarking. Benchmarking is an initiative that compares best practices from other hospitals so that we can improve markers of quality improvement. Continuous quality improvement is when, of course, we continually assess our progress, how effective our care is, how we can improve. Performance improvement, we've talked about, whether that is a formal evaluation, every 90 days with your staff nurses, or through, maybe more simple check-ins and they go around the unit once a shift to check in and see how you're doing. But those performance improvement initiatives from management, they help the nurses grow, improve their performance, promote their professional growth, and ultimately develop their careers. Maybe they want to go into management one day, and that performance improvement initiative can help them get there. Lastly, quality management, overseeing all of those tasks on the nursing unit, making sure that the level of quality, the standard of care that is set, is being met. All right, so the supplies we're ordering, are they the best supplies for our client population? Are we making sure that our supplies are going through a quality assurance check? You know how our glucometers need a QC, a quality control check every shift. Are we making sure that our policies and procedures are quality? All right, so for example, you might see a question asking about chart audits. They're inspecting the unit. They tell the staff nurses to address those discrepancies. What concept of management is that talking about? Which of those management initiatives? Is that benchmarking, continuous quality improvement, performance improvement, or quality management? All right, if we're regularly doing chart audits, inspecting the unit, and then during our meetings, we're letting people know, okay, this month during my chart audits, I found that we are not wiping down our high-touch surfaces or turning the lights off at the appropriate time. This is what we need to do to improve that. We are implementing continuous quality improvement. We are continually evaluating our care and making sure it is top-notch. All right, so if you need more practice on these types of questions, I want to refer you to Rachel Taylor's small group sessions. She offers practice sessions for each area of the NCLEX test plan, where you can apply what you've learned in this video and do practice questions with her while she's live online with you and giving you feedback.